Hello Year 12, I hope everyone's okay. This is the second part of the video for LO17. So if you remember the last video that we did, we looked at drugs and how they work to treat OCD. I am going to do a quick retrieval of that for you, just because it is quite complex. So I'm going to go through it one more time just to make sure that we're as clear as we possibly can be when we're working from home. And then we're going to do the AO3, so the evaluation of drugs. You remember in the last video, the good thing about evaluating the use of drugs to treat mental illness is that a lot of the same evaluation points come up each time. So once you've got your head round the strengths and weaknesses of using drugs to treat psychological illness, you can kind of repeat the same evaluation point across the course in lots of different units. So that's a good thing because it saves on our revision. This will be the last video for psychopathology, so we've done really well because we've managed to learn a whole unit from distance learning, and so I'm really pleased with everyone and all the efforts that you've been making to carry on progressing through the course. You will have seen my message last week on Show My Homework that we will still have an end of unit test as we would have in school. Obviously I'm not there to monitor how you do that test, but I would expect that you would do it as realistically as possible. That means not using your notes. That means giving yourself only around half an hour to do it. That means setting up your station for doing the test, in exam conditions as possible. Sit at a table if you can, have no music on, have no background noise, take your phone away, put your phone away so you can't see any notifications, and just give yourself about half an hour to answer the questions on the test. They are past exam questions from past papers, so the only difference really is that it'll be done on the computer as opposed to on paper. If you want to do it on paper, that's absolutely fine. You can do it on paper and then take a photo of it and upload it to Show My Homework, and I can mark it that way. But the more realistic you make that process, the better, because when you get a grade for that from me, through Show My Homework, you know that's your level of working for this particular unit. So please try to do that. I also I'm thinking of sending out a quick survey monkey before we start the next unit via Show My Homework. And essentially I just want some really sort of honest feedback on how you're finding the way we're working, and if there's anything that I can do to make it more effective, then please put that through in the survey so I can make changes before we start the next unit. Okay, so going back to LO17, I'm going to start off just reminding you of how these drugs work in order to treat OCD. So these drugs are called SSRIs, and they are selective serotonin reuptake inhibitors. Remember, serotonin is a chemical in the brain which we call a neurotransmitter, and the role that serotonin plays is it helps regulate our mood. So throughout the day or the week, your mood will vary over time. Some days you'll feel really happy, some days you'll feel really low. The role of serotonin is to make sure that you never get too high or too low, to keep us as stable as we possibly can be. One of the theories as to why people have OCD is their levels of serotonin are too low, so therefore they can't regulate their mood, and that leads to some of the symptoms that they experience. So the way these drugs work is they combat that by trying to increase the availability of serotonin in the brain. They work at the synapse. If you remember from the last video, the synapse is the gap between the neurons in the brain. Neurons don't touch. A neuron is just a brain cell, and if this is neuron 1 and this is neuron 2, they don't touch like that. There is a small gap between each neuron, and that is called the synapse. So you have the presynaptic neuron, which is the neuron before the synapse, and you have the postsynaptic neuron, which is the neuron after the synapse. The neurotransmitters are contained in little fluid-filled sacs called vesicles in the presynaptic neuron. They travel down the length of the neuron, and when they reach the membrane of the presynaptic neuron, they fuse with the membrane, and that allows the neurotransmitters to be released into the synapse. Once a chemical is in the synapse, it will float across the gap over to the postsynaptic neuron, and there are receptor sites along the membrane of the postsynaptic neuron, and they grab the serotonin, and then the message will continue to the next neuron. Now, that's a healthy brain process that happens in all of us. However, if you have OCD, and the reason you have OCD is because your serotonin levels are too low, what we are saying is there is too little of that neurotransmitter being released into the synapse, and therefore the receptor sites don't have long enough to pick it up. Any unused serotonin has to be removed from the synapse, and the way this happens is through a process of reuptake. That is when the unused neurotransmitter is reabsorbed back into the presynaptic neuron, and then it's put back into a vesicle, and it's restored and repackaged, ready to be used again. Now, if that's happening too quickly and you've got too little serotonin in the synapse, then the chemical hasn't got enough time to get over to the postsynaptic neuron to have the effect it wants to have. So these drugs work by stopping the process of reuptake. Selective serotonin reuptake inhibitors. To inhibit something means to stop it. So these drugs bind to the site where the reuptake would happen, and they stop the serotonin from being reabsorbed back into the presynaptic neuron. So therefore it stays in the synapse for longer, and there's a greater likelihood that it will get over to the postsynaptic neuron and have the effect it wants to have. To get a top grade on a question looking at how drugs are used to treat OCD, you need to be able to explain that process. I did say in the last video, but I'll just remind you, that whole process of how brain cells work across synapses is another LO on the biopsychology unit. You will need to know that. So when we get to do that, we'll do it again and again and again. So please don't worry if you're listening to this and thinking, oh, this is too scientific and it's confusing me. When we come back to school and we do synaptic transmission as part of the biopsychology unit, we'll go over that again face to face. Okay, so I'm now moving on to the AO3, looking at drug therapy to treat OCD. There are 6 AO3 points that are on coloured cards on slide 5 in the presentation that's attached to this homework task. As usual, I'll go through each one, I'll explain whether it's a strength or a weakness, and I'll try my best to give you a label for it. Starting with the green one. Reuptake 2009 reviewed the effects of SSRIs compared to placebos and found that 17 studies showed significant improvement against the placebos. Now, placebos, I hope you know what these are. Placebos are used in lots of drug trials. So when we are testing a drug, we have 2 groups of participants. One group get the real drug and the other group get a fake drug, a drug which does nothing. It's usually like a sugar tablet or something like that. They take the drug, but it's a placebo. It has no effect. Now the reason we do that is to avoid demand characteristics, because nobody in that experiment will know whether they've had the real drug or not. So they can't alter their behaviour because they think they've had the drug. So for instance, if you've got OCD and I give you a drug and I say this drug's going to help you, it's going to treat your symptoms, and then I ask you to come back a week later and I say you've been taking the drug every day, has it worked? You're more likely to say yes if I've told you that that drug is going to improve your symptoms, and that's the placebo effect. So when we do drug trials, we make sure that our participants don't know what condition they're in to avoid demand characteristics. This is called a single blind experiment because the participants don't know. They have no idea whether they're in the drug group or the placebo group. So it gives our research more validity. That's a strength of this particular study or particular review of research. Remember, this is 17 studies. It's not a single experiment. So Sumro has put all of these studies together and said overall, all of these studies show that these drugs work against placebo. So I would say that would be strong support and evidence, and I would probably call it 17 placebos as my label. Okay, moving on to the yellow one. Research has shown that typically symptoms significantly decline for 70% of patients. Of the remaining 30%, an alternative type of drug treatment will be somewhat effective. Now, this is still supporting, but there are a couple of issues to point out. Okay? That's only 70%, so that means drugs don't work for everyone. However, by altering the drug program, the drug treatment therapy, we can try and find something that will work for those remaining 30%. But the word that's quite key in that particular research, it's somewhat effective. So it shows that it's not going to have as much effect. The things with drugs is that not all drugs work for everyone. That's in all studies where we're looking at drug treatment programs, not all drugs will be as effective for all types of people, and usually you do have to amend the dosage, amend the type of drug to try and get a program that works for your patient. So I would call that 70%, and that is still supporting evidence, but there are just a couple of issues in my elaboration that I would pick out. Right, the blue one moving along. Drugs are cheaper to the NHS than other types of treatments. They are also non-disruptive to patients' lives, as the patient does not attend any kind of session. So the good thing about using drugs is you can give them to the patient and say, come back and, after you've taken these drugs for 3 months and we'll have a review. The NHS don't have to pay for a trained therapist or a trained practitioner to have regular meetings with clients or patients. So therefore it saves the economy money. You still have to, the cost of still producing the drugs is still there, but in terms of having a trained therapist to work through these issues, it is much more cost effective, and in lots of ways patients prefer it because it's less demand on them. They don't need to attend the sessions, they don't need to do the work or the thoughts that, you remember from CBT, when we were looking at CBT, that requires a lot of commitment and dedication from the client. Drugs are much less invasive treatment in that way, in terms of the impact that it would have on the patient's lives. So I would say that's another strength, and I would just call them cheap, the label maybe cheaper and non-disruptive. Okay, moving on to the orange one. Drugs have side effects. All drugs have side effects, but the particular side effects for SSRIs are restlessness, blurred vision and loss of sex drive. They're normally temporary, but there are some versions of SSRIs which have quite severe side effects, such as weight gain and aggression. Clear weakness. Obviously, what you have to do when you're thinking about the side effects of drugs is weigh up the symptoms that the patient is suffering against the side effects of the drugs, and kind of like what's worse. Is it worse than me having these symptoms from my psychological illness that's completely taken over my life? OCD can be quite debilitating. It can stop patients from having relationships, it can stop patients from going to work, it can stop patients from having social lives. Depending on how severe the illness is, those side effects could possibly be better than what the patient is already suffering. So again, you have to take each case on a case-by-case basis, but in the main that's a clear negative and side effects. And I would just couple of examples of side effects, so that when you're doing your elaboration in the exam, you can clearly show the examiner that you know what particular side effects are relevant to these drugs. Two more to go. The blue one. There is some controversy surrounding drug research. Some believe that evidence supporting drug treatment is sponsored by drug companies who only include the positive evidence. So when a drug company is responsible for trying to find a drug, they stand to profit significantly if they can find a successful treatment, because obviously the NHS will want to buy it, and therefore they can get a lot of money out of that. So there is a lot of controversy around this, and lots of people feel that the evidence that's presented in terms of how effective these drugs are is sometimes flawed and is sometimes skewed to show us only the positive effects rather than the negative effects. So that's a weakness again, and I would call that controversy. Last one, Julian reported that although studies show that patients taking SSRIs don't recover fully, between 50 and 80% improve enough to let them lead a fairly normal lifestyle. So this is another strength, but also a little bit of a weakness, because it's just reiterating that point that they don't work for everyone. So although drug treatments allow people to get back to work, it's not going to completely remove the illness. The illness will still be there, and you can remember from some of the other treatments that we've looked at in this unit, this idea of symptom substitution. These drugs are not getting to the cause of the OCD. The person has the OCD for a reason, and unless we understand what that reason is, it's never going to go away completely. And while the drugs can mask some of the symptoms and help the patient have a relatively normal life, they're not going to be able to remove it completely. So that's all of the AO3. Please cut and paste it, stick it in your book, fully elaborate on why they are strengths and weaknesses, and then answer the question. Thank you.